Good afternoon, Dr. Wingate and Dr. Veneno. My name is Thomas Isle. My partner is Sasha Pierre-Paul. And today we'll be doing a critique on an article about amoxicillin versus placebo for acute otitis media for treatment in children under 2 years of old. So without any further ado, let's get started.
So what is otitis media? Otitis media is an infection of the middle ear caused by a pathogen such as a bacteria or a virus that causes pain, inflammation, and swelling in the middle ear. As you can see in our picture, we have our normal middle ear that is absent of any fluid, while the otitis media ear has an infected part in the middle ear that's filled with fluid, which obviously would be quite painful. So signs and symptoms would be pain, inflammation, buildup of fluids, difficulty sleeping, fever, headache, and crying. The tests used to diagnose acute otitis media would be a pneumatic otoscope to see into the atrium and look for fluid. For our methods, first we have our study design and our research question. Our study design is a practice-based, randomized, double-blind, placebo-controlled trial. This study design was perfect for us because it allowed for our results to be without bias from our experimenters or from our researchers. The double-blind studies also prevent bias due to demand characteristics or the placebo effect. Our research question was to determine the effect of antibiotic treatment for acute otitis media in children between ages 6 months and 2 years of age. Physicians advocate for less antibiotic treatment for otitis media due to complications and set out to test if antibiotics were actually more beneficial than placebo.
So patients were determined and split up into two groups based on whether they were eligible or not eligible, based on exclusion and exclusion criteria. A total of 425 patients were originally selected who had acute otitis media, and from there they were determined not eligible based on the exclusion criteria that we'll get into, and eligible. 362 were determined eligible, and from there on, 240 patients were entered into the study. And then data was collected on day 4, 7, and 42. So the patient population was 240 children aged 6 months to 2 years with the diagnosis of acute otitis media. Inclusion criteria for the study include the age range that was just mentioned, 6 to 24 months, children present with the acute otitis media or acute otorrhea, or one or more symptoms of acute infection, fever, headache, general malaise, recent irritability. Exclusion criteria, which excluded a certain amount of patients from the study, include whether they had taken antibiotics within the last 4 weeks, whether they had been in the study previously, proved to be allergic to amoxicillin, or had a compromised immunity, craniofacial abnormalities, or Down syndrome. The study period for this experiment was from February 1996 through May 1998 in the Netherlands. Subjects were taken from only the Netherlands. The power analysis showed a calculation of sample size that was based on the assumption of a minimum difference of 20% in the primary outcome between groups, with an alpha of 5% and discriminating power of 80%, and an estimated 60% persistent symptoms in the placebo group. The total number of children required for the study was 79. However, 240 were selected to participate in the study.
Method statistical analysis. For these analyses, all were carried out using SPSS with an intent to treat basis. First, the odds ratio. This test was used to compare for persistent symptoms at day 4, clinical failure at day 11, occurrence of middle ear effusion at 6 weeks, and side effects in both arms of the study. The difference in risk of these characteristics was done using the odds ratio with a 95% confidence interval. Our Kaplan-Meier curve. This test was perfect for us and advantageous as well because it took into account time of event, which is very important in the results of the effectiveness of amoxicillin versus placebo. This allows us to compare survival times for both groups, where survival time, in this case, is fever, pain, crying, or both. The test also allows for censoring. When diary data was incomplete or the last diary entry recorded a fever or pain in the child, then that entry was censored in the survival analysis. differences between the two groups were tested using a log rank test. The Mann-Whitney test, a non-parametric equivalent to the independent t-test, while not as powerful, was used to look at our data that did not follow the normal distribution assumption. The sample size is quite large, so we could have used an independent t-test, but they also have large differences in homogeneous variance. This test also found the mean differences between the two groups of analgesic consumption and not the median. When doing a Mann-Whitney test, it's more beneficial to do median rather than mean. The experimenters should have normalized their data using mathematical transformation, such as log or square root or inverse, in order to determine the difference in means with an independent t-test, which would have also been more powerful. The logistic regression analysis was done to determine the effect of a single factor on a binary outcome. This was also very beneficial for our study. The test also adjusts for possible confounding due to unequal distribution of baseline characteristics, such as reoccurrence, daycare, and smoking as all possible confounders. The chi-square test was done to determine the association between two variables and we found this to be very appropriate for determining persistent symptoms.
Treatment variables. So the independent variable for the study was whether the participants were placed in the placebo group or in the treatment group, which was amoxicillin suspension 40 milligrams per kilogram a day, the placebo being a placebo suspension, both being very similar, which was a strength of the study. The dependent variable was persistent symptoms at day 4 and duration of fever and pain or crying or both. Otoscopy at days 4 and 11 and thermometry at 6 weeks and use of an analgesic. Confounding variables that were present in the study composed of unequal distribution of baseline characteristics such as recurrence, daycare, and smoking.
For result statistics, the study found that symptoms were persistent at day 4, with a difference in risk of 13% and a significant p-value of 0.03 in the placebo group compared to the treatment group. Loss of fever was faster and duration of pain was shorter with the amoxicillin group. This was found using a log rank test. However, only fever duration had a significant p-value of 0.004.
The critiques that we found in the study, adding on to some of the critiques we've already mentioned throughout the course of this presentation, some of the strengths and weaknesses that we've mentioned beforehand, included the use of a non-parametric test, which was responsible for 2/3 of the significant p-values found in the study. This is a less powerful test, and a parametric independent t-test could have been used to incorporate a more powerful test into the study. Also, furthermore, more analgesics were used in the placebo group, which could explain the lack of difference in duration of pain or crying. If this was controlled for, there could have been significance here as well, thus strengthening the experiment. Furthermore, the use of untrained parents to document secondary outcomes in a diary, secondary outcomes are defined as persistent fever, air rate, crying, being irritable, or no improvement in the appearance of tympanic membranes, etc., also was a weakness in the study, which could have included inaccuracies in data recording.
This was a double-blind study that did an excellent job cutting out bias on part of the experimenter and the subject. This allows for the test results to be more reliable. The sample size was also large enough to acquire significant data. So in conclusion, this study found the number needed to treat. 7 to 8 children aged 6 to 24 months with acute otitis media need to be treated with amoxicillin to improve symptom outcomes at day 4 to cure 1 child. This study also found that it is not imperative to treat every single child with amoxicillin that is symptomatic with acute otitis media in this age group. It is okay to use watchful waiting.
Furthermore, another conclusion brought up by the study was that amoxicillin 40 milligrams per kilogram a day is still the treatment of first choice. The dosage was deemed sufficient because of the incidences of resistance to Streptococcus pneumoniae and influenza in the Netherlands remaining low. Also, in addition, this may be very different in cities around the world, so this study cannot hold true to other cities. It is strictly in the Netherlands where it is useful.
Okay, we just want to say thank you so much to Dr. Wingate and
Dr. Meneno. We thank you so much for the time that you guys, for watching our presentation and the time you guys have dedicated this semester to educating us in order to present this presentation in front of you today.
Yeah, we definitely could not have done it without the resources and teaching you guys have given us.
Thank you.
Yeah, thank you so much.